Good afternoon, everyone. My name is Dennis Pearson, and I am a program manager here at the Center for Quality Improvement and Innovation. And this afternoon, our presentation is constructing the Fishbone diagram to be presented by Quality Improvement Advisor Amanda Norton. Let's just give it about another minute or so to wait for other folks to join us. I'm going to put myself on mute for a moment. Thank you. Okay, I think we're going to go ahead and get started. So again, let me introduce our presenter for this afternoon, Amanda Norton. Amanda, could you briefly just introduce yourself, please?
Absolutely. Hi, my name is Amanda Norton. I'm a quality improvement consultant and have been working on a variety of quality improvement activities and efforts in healthcare for about 15 years now. So I'm a social worker by background. I live in New York as well. I come to you from the Ithaca area, so I'm happy to be with you today. So I am just here to talk a little bit about this tool and any other tool that you might want to have access to as we move forward. So thanks so much for having me.
Great. Okay. All right. So we can go ahead and get started.
All right. Does that mean go? Okay.
Absolutely.
So, all right. Welcome, everybody. So today we're here to talk about fishbone diagrams, Ishikawa diagrams, cause and effects diagrams. You can call them anything that you'd like to. I don't like to get too lost in the name calling of them, but we're going to spend some time thinking about how they can be helpful in the various activities that you're working on. If you have questions, please stop me. Please also participate. There are going to be key moments of this presentation where I'm going to stop and ask somebody to come help me come up with an example and to work with me. I'm painfully comfortable with silence. So if I have to sit there in silence while I wait for somebody to join in, I'll do it. I'd rather not though. So let's try not to make painful, awkward silence the thing that we do this Thursday afternoon. And feel free to chat in questions. If I miss them, I will definitely get back to them. So let's move on. Now I'm leaving right now the presentation in this mode so that I'm able to also type in when I get some willing volunteers to participate with me. If anybody's having a hard time seeing it, please let me know as well. So a fishbone diagram. It's a scaly looking, well, a kind of naked looking fish, but it's called this or an Ishikawa diagram. Which will go into the founding or the base of it in a second, but it's called a fishbone diagram because once we create it, it looks a lot like a fishbone. I can't see a whole lot of faces, but I am curious how many of you have heard of and or used one of these before. So if you're willing to chat in a yes or a no, I would love to see just a general sense of, have we worked with these before, or is this a brand new comment or a brand new, oh, all right. So I'm looking through, I'm seeing a handful of yeses, one no, couple no's, some are comfortable, some have heard of it. All right, so let's keep going through it. And for those of you who are saying yes, or that you've used it a lot, you sound like you might be the people that want to volunteer for my example later. So I'm excited to see that. So what are our learning objectives today? Our learning objectives today are to discuss the benefits of constructing the fishbone diagram, to assess the cause of a problem, to identify the steps in constructing it. So how do we actually do it? To discuss how to successfully use the fishbone diagram to identify and address causes, and to build your own. So this is something that I do want you to leave with more comfort. If you're already comfortable and you can attest to the benefit, please feel free to chime in and attest. I do believe that diagrams like this you can look at them and say, well, I don't have time to do that. And it's really easy to say that and feel that way. And you're right, you guys don't have a lot of time. But here's what I can tell you. Taking the time to do this will make the work that has to happen flow so much easier. It will make the likelihood that you're addressing and working really hard to fix the right problems. I'll have more confidence in that. So while it is a little bit of upfront time, and make sure work down the road, the work that you have to do, because there is a problem at hand. That's the reason we make these fishbone diagrams, is because something is not working right. So it'll make the work you have to do down the line much, much easier and more likely that you're working on the right thing. So let's get into this a little bit. So will the real stand up? This idea that this diagram does go by a lot of different names. And again, I don't particularly care what you call it. But we should just acknowledge that if somebody says, oh, well, let's make a cause and effect diagram, they're talking about the exact same thing as an Ishikawa diagram or a fishbone diagram. So you can use these words interchangeably. You don't have to pick the most difficult one in order to play stump my colleague. Just choose whatever works and get everybody on board. Why is it called an Ishikawa diagram? Because he is the one who created it. So this was created by a theorist and professor at the University of Tokyo. And really the purpose behind the creation of this diagram was to increase internal cooperation and coordination to positively affect the customer's needs and ultimately leads processes to be more efficient, better quality of products and services. And so, coming from Tokyo, we have these opportunities, and it was a manufacturing world, to really think about how do we improve our efficiency and our effectiveness? How do we get our products as strong as we can and out the door? And so this was developed, I believe, in the early 60s, but please don't quote me on that because I'm not looking at the date directly right now, but I believe it was the 60s. What are the benefits or the importance of this? Is it displays all the possible causes of a particular problem. So, when I work with a team, and I spend a lot of my time doing coaching and practice facilitation and interventions directly with teams, and when I work with them, we'll identify a problem and people will just start throwing out reasons why, causes. What causes that? Why is that happening? Why is this happening? And sometimes it feels like you're throwing spaghetti at the wall and just trying to see what sticks. Sometimes you feel like you only get the causes that come from the loudest person in the room or the most influential person in the room. And so one of the strengths of this diagram is it gives you the opportunity to just get all of the causes out. It categorizes your thinking in a way that is really productive and effective. And we'll talk about those categories a little bit later. But it gets you an opportunity to do some brainstorming, get everything out there. And it really captures the relationship. If there is a cause, what is the potential relationship to the overall problem? And what are other things that are probably influencing that cause? It's really good for solving complex problems. And let's be honest, in healthcare and in HIV care, we have complex problems. I often joke that, it must have been nice to develop some of these tools in a manufacturing world where you could just tweak the machine and the machine would produce a different result. We aren't given that luxury in healthcare. We have all of our elements that are at stake here are not, they're not machines. And so there's always some flexibility in what's going to happen when we make some of these changes. And it simulates really in-depth analysis. So it allows you to dive deeper and find out what's going on specifically for this problem and specifically within your organization. So I know you all have received enough quality improvement training at this point to know that one of the foundational principles of quality improvement is every system is perfectly designed to get the results that it gets. It's one of my favorite quotes. Friends of mine who know me in a non-work environment would ask that I stop saying that, but it's constantly going on through my head. So what's nice about this diagram is it does help you see the system at play, because the problem is a piece, but it is not all of those parts of the system that are influencing why you have that problem. So it also gives you a bigger picture. So sometimes what we see as a problem is not really, like, we haven't gotten to the root cause of the problem yet. It's a symptom of the problem, but it's not the actual problem. So it does help you understand the problem's bigger. It really facilitates brainstorming. So it boosts and frames the way that you do some brainstorming. What I love about a fishbone diagram is that no idea has to be perfect. So when you're creating them and you're thinking about causes, in the beginning of the creation of a fishbone diagram, you really can think of and brainstorm any possible cause. You can be creative, you can be unexpected. You can really think of what you suspect might be the cause, whether it's mainstream or not mainstream, because it gets the discussion going. Sometimes it's those, what you always think is the problem, which, let's be honest, we tend to say, well, it's, a certain staff member, or it's a certain, we don't get the supplies we need, or we don't have the scheduling we need, we don't have the staff we need. So we tend to fall in these typical categories. But doing a diagram like this really encourages you to think outside of those boxes. Helps to keep your focus, because we all have been part of those team meetings where there is no focus and they are not enjoyable. And it really pinpoints places where things are not working. So I have not seen any questions, but as I said, if you do have questions as we go along, feel free to put them in the chat. So let's start by talking about the problem. So any good fishbone diagram starts with a really well-written problem statement. And when I say well-written problem statement, it is not about your grammar, and it is not about, how many new and innovative words you use. It's about how well you've really dug down to identify the actual problem at play here. And one of the tools we often use is the 5 whys. And again, if you've heard of 5 whys or used it, feel free to chat in a yes or a no. But 5 whys is not mandatory. It's not a requirement to creating a fishbone diagram, but it is a really useful tool. So what do I think is one of the number one flaws in creating a fishbone diagram? It's that you don't have the wrong problem statement. You don't have the right, you don't have the right problem statement. You haven't kind of really gotten at the root cause of the issue. It's just a symptom. It's a surface level issue that you're encountering. Now, do you have to have 5 whys? So what it asks you to do, the 5 whys, is you come up with your problem. My problem is I'm always late to work. Why? And you continue to work through, you just continue to ask yourself, and we're going to ask that question. And I'm going to ask one of you who is perpetually late to work to tell me why in a second, but you just continue to ask yourself why. So it aims at getting closer and closer to what we call the root cause, which is the actual reason we have this problem. Most quality improvement, when it's done poorly, it's because it's not addressing the actual root cause, it's addressing the symptom. We do this systematically so that we can work through each of the issues. And it is one of the most useful tools, but simplistic tools, I think, that exists in quality improvement, because you do just continue to ask that why. And I ask it of things all the time. If we have a new form to fill out, I'll ask why. So we have this new form to fill out. Well, why? Because we need more information on the patient. Well, why? Because we need to get that information to the governing body. Well, why? Because they're the one that gives us money. Okay, so we need to figure out how to get the right information to the people who are funding us. All right, now I understand why. It's not about the form. It's about getting information to the people who give us money. So it does look at the bigger systems. And there's also, you can sometimes ask the 5 who's, like who needs this information, or who is involved in part of this work that we're doing. So an example is, my computer shuts down hourly. Well, why does that happen? Well, because my computer is 7 years old. Why is your computer 7 years old, you may ask? Because we never bought new ones. Why didn't we buy new ones in the 7 years that we've had? If we think of technology, a 7-year-old computer is basically like saying dinosaurs might still exist. So what comes next? Well, why didn't we buy new ones? Because it's not in the budget. And why has it never been brought up or put in the budget? It's because we don't have a central person that's in control of IT. We don't have an IT person. And why don't we have an IT person? Because they retired and we never did anything about it. Well, so our problem is not necessarily that your computer shuts down hourly. The real problem is that we lost a critical piece of our organization, an IT person, and we never filled that problem. So one of the symptoms is that your computer shuts down hourly. Another symptom might be that your protected health information is a bit at risk because nobody is managing and controlling the PHI that comes through your organization. That would be another symptom. Now, that is a much more impactful and shocking system that people are going to pay attention to than your computer just shutting down every hour. But the why, as we continue to dig into the root cause, gets at this bigger issue or this more specific issue of we don't have a person in charge of IT. And without that, we're having multiple symptoms across the way. So I do see Elaine said that you are using 5Ys after in conjunction with an affinity diagram. That's really great to hear. So can we see how we went from my computer shuts down hourly to this larger organizational systematic issue at hand? So the example that I wanted to work on was, why am I always late to work? It doesn't have to be that. If somebody else has an example, I'd like to just kind of 5Y away with somebody. So who wants to say why you're always late to work, or why use something?
I go to bed too late.
You go to, okay, why do I always, let's change it. Okay, so why do you always go to bed too late? Why is that?
Because I'm watching the news.
And why are you watching the news?
Because I want to see what's going on in my community.
And why do you want to see what's going on in your community?
Because it's important to me to understand the issues and to see some of the positive things that are going on.
And why is that important to you?
To be encouraged especially by the positive things that are going on, but to also just be aware of the issues outside of my own little neighborhood or community.
Okay, so to be connected to your community.
Yes.
But also encouraged. And why does that matter to you?
Because I care about people.
Is it people or your community?
I care about my community, but my community can be my immediate surroundings, but it can also be the community at large, the other parts of the city that I don't live in.
Okay. And is there a sixth why that's important to you? Is there kind of a bigger reason why that matters to you?
I just love my city.
And you want to see what's best for your city?
Yes.
Okay. All right. So going to bed too late and watching your city thrive feel like kind of completely different issues, don't they, Elaine? Was it Elaine that was talking? I couldn't quite see who was.
Yes.
Yeah. So first, thank you for volunteering and not making us sit in awkward silence for too long. But this idea, and so we went to 6Ys because there were a lot of things for us to unpack or for us to see in here. But to write a fishbone diagram with a problem of how my problem statement is, how can I work to see my city thrive and succeed? Those are very different than I'm going to bed too late. So when you're going to bed too late, you might have, if you're thinking about what causes you to go to bed too late, it could be watching the news. It could be because you have an intensive facial skincare routine. Could be because you work out in the evenings and you spend too much time doing that. It could be because, like me, you have tiny people in your life and they don't seem to ever get tired. And so you are not going to bed at a reasonable time. So, but what it really got down to as we 5Y'd through it was more about a general interest in your community, wanting to see it thrive. And you want to look at the news because I would guess that there is also a why in here that you also, while you want to see it, you also want to see where you potentially play a role in your city thriving. Is that a fair jump, Elaine?
Yes.
Like, I don't get the sense that you just want to be like, oh, well, everything's falling apart. That's okay. Like you want
right.
Also see where you can piece yourself in as a way to support the success and strength of your community.
Yeah,
that's great. So that means you also, like, the problem, as we're thinking about a problem statement, is that you might think that your problem or your city is struggling and needs some support to make it better, because you do love it and you want to see it thrive, but the problem might be that you've got some concerns.
yes.
All right. Thank you so much, Elaine. So while that was a completely non-work related example, to me, these examples are the ones that make me pay attention to why 5 whys is important. Now, had we just done a fishbone diagram around the problem is I go to bed too late, we would have come up with many things that we could work on, none of which are getting at the actual problem. And so I love this diagram because you all have plenty of work to do, and you don't need to be wasting your time fixing causes that are not actually getting at the true problem. And so if Elaine spent all of her time coming up with a better nighttime routine, it still wouldn't make her feel any more connected to her community and would not make her feel any better prepared to address the problem of her community being struggling right now. And so she could work really hard. She could spend a lot of time. She could make a million forms. She could do whatever that work might be, but it's still not going to get at that thing that kind of is in her gut in this particular scenario and is the true problem that she's trying to address. What she wants to probably do, what some of the causes or things she might work on are volunteer opportunities in her community, ways to build engagement with some of her friends, or how she's going to get others involved in building and supporting the community, thinking about, doing benefits or donations or, a million things. Those are completely different activities. So now that we have a problem, now that we've really dug down and did the work, and I'm here to tell you that's not easy work, especially in a work environment. When just Elaine got to decide what the whys were, it was easy for her to do that. When you get several conflicting opinions in a room, it can take some time to really get at those 5 whys. When I have done this, just, I guess, tips from the field, when you're working with others, I've sometimes done this individually. So if I was the team leader, I would interview each person. So if we think this is our problem, I would 5 why them individually and look for commonalities, or have an opportunity to say, okay, these are the things that we heard when we did the 5 whys individually. I have done it in a big group, and you just have to be a good and strong facilitator in order to get everybody's opinion heard as you're continuing to dig down. And you'll see where it branches off occasionally, and that's fine, because as I said, part of this is really brainstorming and learning how you're able to find the different whys. Sometimes it's not a why, it's a cause. It's a cause that will end up in your fishbone. So we've got our effect, we've got our problem. It's clear, it's concise, and as a team, we've agreed upon it. So this is the head. This is the main box of our fishbone diagram. Now we're going to work on making the spokes, or the kind of bones of it, that are the causes. What is causing this to happen? And the main causes are usually, there are a handful of kind of standard categories that we work from, and we'll talk about those. Or you might find that the categories are really specific to the work that you're doing. And so the categories are flexible, but they should be different so that you're able to have kind of different buckets or segments to put your work in. So you can use the standard categories. You can continue to ask why and see if they give you some of the categories of your causes. But be careful with your 5 whys. We can sometimes just go a little bit too far or get a little too into the weeds. And so you want to be careful there. When you're thinking about different categories, if you're running low, you might say to your team, let's just look for one more and check to make sure that logically you feel like you've caught all of the potential categories. Now, what are some common categories used? They're going to feel pretty simplistic when you look at them. So commonly the categories, or the spokes of the fishbone, are going to be people, methods, equipment or resources, and environment. There's also, we sometimes go through several M's. There are different ways that we can do this, but people, so anyone who's involved in this. So we use Elaine's example. The people involved might be her, it might be family members of her, it might be friends of her. We want to think of methods, the process that is performed to a specific requirement for doing it, such as what are the systems, the policies, procedures, rules, regulations. Now, for Elaine's example, it would be more, where's the TV? What are the methods to getting at it? What are the things that are keeping her up too late? Is it a continual scrolling situation? What is that? And that also gets into some of the equipment. So what is the actual things that we're using for this particular problem we're looking at? So when we think of a healthcare problem, we're thinking about the computers, the medical equipment, the blood pressure cuffs, the things that you need. And they can also be some of the things that the people who are coming to you need. So bus passes, car, childcare, what's required in order to get the job or task completed. And then the last thing that is a common category is the environment. So the conditions such as location, time, temperature, culture within the process, and the impact that it's having on your specific problem. So when we put it together, we end up looking at a diagram that looks something like this. So your problem is the head of your fish. And then we have equipment, methods, people, resources, and environment. So these are the things that are going to influence, and it's easy to begin to think about what are very, very specific examples that would go into this. If we look at an example as we just kind of continue to get from the general into the specific, so if we're thinking about a cause and effects diagram, because the problem is a patient doesn't keep an appointment, the environment would be the conditions in which the process is happening. So why does the patient not keep the appointment? It could be a problem with the bus schedule. It could be a problem with your overall location and parking. It could be because their child was sick and they weren't able to keep the appointment. But it gets at those specific conditions which are influencing the process. Equipment, so information systems, machines, what is required to actually have that happen? Did we remind the patient? Did we use our equipment to remind them that they had an appointment? Did we check them in on time? Did we do the things? Are there equipment issues around them keeping that appointment? The method is going to get into how the process is informed. Did they wait so long that they left? So is that why they didn't keep the appointment? So what are some of the methods or procedures that are standing in the way of us being able to help patients not keep an appointment rather than not keep an appointment? And then the people who are involved. Did the front office staff forget to make the phone call? What is there no, person who typically makes reminder phone calls right now? Did that person quit, or are they not any longer with the organization? So thinking only about this really small issue, which is an important issue, and we see this all the time, that people don't keep their appointments. But when we use that as just one person who didn't keep their appointment, and we dive into the individual causes that led to that, we see a lot of things begin to bubble to the surface. Now, we're looking at this from an organizational level, not from a like an individual level. So when we're looking at this and when we're creating our own fishbone diagrams, here's a word of advice from me. I would encourage you to think about the most common causes. Another trap that I see people fall into is they think of the one time something went horribly wrong, and they create a bunch of causes that are on that one bad experience. I often joke that our TSA functions this way, and it's not to pick on the TSA by any means, but they tend to be very reactive. They think about the one time we did something very, very wrong, and it is important, and we can't have the TSA messing up, but they make entire solutions based on just one issue. And so while you're doing your own cause and effect diagram, I really encourage you to help people, whoever you're working with, to think about the common causes, the things that you see happen a lot for a lot of patients or for a lot of staff members, not the worst case scenario and the one time everything went wrong.
Excuse me, Amanda, let me just jump in for a second. There's a question in the chat, I think, and that's from Teresa. And it says, so just to clarify, you asked 5 whys for each category?
Teresa, really great question. So you start with the 5 whys to create your problem statement. So to create your fish head. You can use the 5 whys when you're thinking about environment. So I would start with the problem statement, the fish head, and because the 5 whys get you closer and closer. Now, in the environment, you might find that there are some specific problems, and you might ask yourself, well, why is that a problem? I don't think you typically are going to need 5 whys when you're getting into the causes. So when you're getting into these spokes over here, but that's a good example of when you possibly could. But for the most part, Teresa, I would encourage you to use the 5 whys specifically for the problem statement. Does that answer your question, Teresa?
Yes, I think so, but I think I have a follow-up question.
Okay, go for it.
So we have the problem statement, but then we have these categories. So I think I'm just a bit confused as to how you're deciding. I understand what each category discusses, but how do you decide what to focus on for that category?
So how do you trailed off just a little bit on me at the end there. So how do you decide what to focus on within the categories? Is that?
Yes.
So that is where, as a team, you begin to decide what are the things that are happening. What is the truth of the environment? You're going to use, if you have data to support you, you're going to use data. If you have patient surveys, so you've got some patient experience or family experience, you're going to use that. You're going to use the information of your system to identify the things that are currently happening. And so deciding what you focus on, we're going to get to that as we move through the cause and effect diagram. But in the beginning, you're just trying to get, as different spokes of this, the problems at the causes as you see them, as you know them of your healthcare system.
Okay, yeah, I think that's my question. So if the problem is patient does not keep appointment, what is an example of an equipment problem that could prevent them from keeping their appointment? Like, how do you decide what those are?
So one thing I would say to you, I'm hearing maybe a little tension between I'm actually feeling a little tension between, is it equipment issue or is it a methods issue? So one thing that comes up to me is, what if the patient doesn't keep their appointment? And what if you have been using like text reminders, a system for text reminders, and you just stopped using that system or just switched over to a new system? So patients aren't getting those text reminders anymore about their appointments. To me, that's an equipment issue. You don't currently have the equipment that you did have to remind patients to keep that appointment. Does that clarify?
I think so, a little bit.
Okay, let's keep working on it. And if it doesn't, 2 things, I will make sure that my email address goes into the chat at some point so that you can email me if questions still exist once we're done. The tension I was feeling is, to me, having a text reminder system is an equipment system. So it's something that you sign up, you get the information out there, and its job is to remind your patients when the appointment is. Methods might be, we have a person who does those phone calls and they forgot to do it. So the method or the process failed it. Maybe the front office staff is supposed to call everybody the day before and the woman didn't call, or the man didn't call. And then a people issue might be, well, we have this process to call, but the person doesn't exist anymore. Now, I wouldn't get too bogged down in, did I put it in the right category? Just finding out exactly what the issue is. So if the issue is that you don't have that system working correctly right now to automatically send text reminders, that's an issue. Like, it needs to go in your fishbone diagram. If the issue is, Susie was the front office staff who made the phone call and we haven't replaced her position since she quit, that's a people issue. But it's still an issue. It doesn't matter if it goes in the right category. It's diving into the specific reasons why you're having this problem. So let's keep working through. There's an example about hamburgers that might help us dive into some of these details as well. So we talked about this. What I like about this graph is, you have your main causes or main categories, and then at times you're going to have sub causes or subcategories, things that go into play as we work on this. So I like this example because it has absolutely nothing to do with healthcare, and I think sometimes they're the best. So what is our problem? We've got bad burgers. For the vegans or vegetarians in the room, I apologize. We'll pretend like they are meatless burgers. For everybody else, we just have a bad burger and nobody wants a bad burger. So what, if we think about the personnel issues, there was a mishandling of the burger. Now, what are the some of the sub causes of mishandling a burger? It could be unhygienic storage. It could be insufficient training on how to cook and store. So these are, we're just saying for this particular example, these are the things when they dug into the weeds of their system, this is what they found. Burgers were being mishandled because of unhygienic storage and insufficient training. Those who were making the burgers weren't stored correctly. Measurements. So incorrect quantity of spices. That could be the measurement of how we're preparing these, and those quantities are not correct. Environment. Too hot. So we cooked it too hot and it impacted the quality of the food, and the humidity was also affecting the quality of the food. To me, when I think of environment, I think of, going to McDonald's and the burgers lay out forever. And so the environment is influencing the quality and you get a bad burger. Machines, so the storage and the cooking equipment. So poor hygiene or poor maintenance of the machines, the grills that are physically making the burgers. The methods, so methods and measurement, the causes here can be related. So the recipe is flawed or not followed. And that gets into our issue around incorrect quality of spices. So it doesn't mean that these things stand completely alone. We know in systems thinking, everything is pretty interrelated, but there's two different issues here. Is the recipe itself just flawed or not followed? So if it's flawed, we need to change the recipe. If it's not followed, it means the incorrect quality of spices is because it wasn't followed. And then materials. So is our raw material unhygienic? It's not fresh. It's not prescribed quality. It's not as good as we wanted it to be. So Teresa, not to put you on the spot again, but does looking at an example that has nothing to do with healthcare, does it help us dive into, what you might put under these categories a little bit better, or are there still questions that exist for you?
I see the category, but I'm just in my head, I wouldn't say bad burgers and then think, oh, maybe it's because our machine is not storing and cooking the things correctly. Does that make sense?
So what would you jump to if you had bad burgers?
I am not sure. I think, is this the things you're putting under these categories, is it based on something is it backed from surveys or something, or is it just you're thinking of it in your head and putting it down as you go?
So the method for getting this information, the way, let's, I guess, go back to healthcare, and this would be applicable in really any industry. Some of it's going to be surveys. Some of it's going to be observation. So you might shadow the staff as this is happening. You can shadow in a medical appointment, or you can shadow, watch somebody make burgers and see what happens. You're going to walk around the environment and see what's going on, look at the equipment and see if there's poor hygiene on the grill that hasn't been cleaned in a while. So the way that we're collecting the information, I think we're, if I'm hearing you correctly, Teresa, one of the things that you're talking about is, okay, so I've got my categories. How do I get the information that goes in them? And some of the strongest tools for doing that is going to be any sort of consumer or provider feedback. It's going to be just physical observation. So I will often say when we're doing this, let's do a walkthrough with a patient, or let's shadow a staff member to see what's happening. If our problem is long wait times, let's just sit in the waiting room and see what happens with the patient. And that way we can begin to collect some information about what the experience really is like and what's happening around wait times. Let's shadow a nurse who's getting ready to bring a patient in and it takes a while, and let's figure out what happened to that, like why we ended up in that place. So you're right, you do need to collect some physical data in order to fill in these categories. And those are some strategies. And then just looking at your data. Is wait time really an issue? What is our wait time? Is it 30 minutes? Is it 5 minutes? So you're going to want to look at concrete data, visual data, and then any feedback you're getting from patients and families to support you and where the problems truly exist. And that's what you put in here. It's not what you suspect. It's those problems that you really have confidence, those causes you have confidence are leading to the overall and the larger problem.
Thank you. That was my question.
Okay, great. Any other questions since we've kind of stopped now? I see that my email has made it in. Thank you so much, Dennis. Other questions that we have, or actually I would turn to the handful of people who've said you use this all the time and it's really helpful, and ask you if you have any tips or advice that you would recommend at this point. So around how you have selected some of those causes as you've done this internally. Who's got a good story for us? So Wanda, you say that you use it a lot. If you're able to come off mute, are you able to tell us, give us a little bit of your experience around finding the different causes?
Hello, hi.
Hi.
Here my team says that I am the fish girl, because the way we use this diagram is after a brainstorm, thinking about a problem like, let's say, viral suppression, something that we used to work a lot. Low viral suppression should be in the head of the fish. And then the other things of the fish, we start thinking about the main causes for the viral suppression, for the low viral suppression. So we start with people, what happened with people. We include patients, we include our employees, support that the patient needs that is not addressed to. Sorry for my English, I had to switch my brain to speak in English. Other causes, like lack of follow-up from the case manager, and so on, different things that can influence in the patient low viral load that we can handle, because sometimes we think about some issues that we are out of our hands to manage. So those things that are not under our control, we take it apart. So we have to look for the causes that we can handle or manage to improve the issue that we have in the fish head. Do you understand?
I do. Can you give me an
Dennis,
example?
did you understand me?
Yes, I certainly do, Wanda. And let me just quickly say this. Wanda, thank you for your participation, everyone. Wanda is actually calling in from Puerto Rico, and we know the many challenges that they're going through right now. So thank you, Wanda. Thank you.
Thank you so much, Wanda. And Wanda brings up a really great point that I was going to talk about later, but we'll talk about it now. You can include things that you cannot handle on your fishbone diagram, but it's important to indicate it in some other way, because this is going to happen as you have a problem. Wanda's was viral suppression load, and thinking about the different causes that yield that. And there will, regardless of the problem, be things that outside of your control. So what I often tell people to do when they're creating a fishbone diagram and they're doing it in some sort of computer format is to color code. So if you have something that is a cause and you know it's a cause, and people sometimes get frustrated if we don't put the causes on there that are big and impactful, but you can't do anything about. So sometimes it's policy changes, sometimes it's insurance coverage. It's just these big systems that are outside of your control. I tend to say, put those in red so you visually know it's there, but it's also a little bit outside of your control. Another good way to color code is to use like kind of the green and yellow. So the green are the things that you're going to focus on first, because when we get one of these diagrams done, there's going to be a lot of causes. And your team is going to say to you, we can't work on all of this. So if you select, say, no more than 5 and put them in green, you know these are the causes we're working on. The yellows are the ones that are on the, like, next on the list or on the list, but not yet. And the reds are the ones that are important and impactful, but outside of our control, and we can't potentially change it. Wanda, do you think something like that would work for you guys? Yeah. All right. So this is a busy fishbone diagram, and I show it to you for one reason and one reason only. A, it's really well created, but what's nice about the way they've done this is if we take this, so we're looking at application lead time is longer than the specified 3 business days. And so one of their things is around underutilized talent and insufficient training. But what's nice about this fishbone diagram is it physically shows you how these different issues interact with one another. So I like that. I said to you before, it's a system, so there's going to be influence upon each other. And this idea that, right here, it's the social workers spending time on vouchers, which is important in underutilized talent, but it also relates to priorities are unclear. And so what's really nice about this fishbone diagram is it shows you that none of this sits in a system sits in a silo by itself systematically. If the priorities are unclear, it's going to influence other things on this fishbone. So I would like to practice. We have about 15 minutes left. And I'm curious first if there is a concrete problem we can work with somebody on identifying. What is a problem that you're currently working or have in your organization? And some of you have said you heard of it. We have one person who said you just learned about it this week. So maybe you want to give us a problem and we can begin to test it out with the larger group. I'm scrolling down because I see a new message. HIV treatment fatigue. All right, Sky, can you come off mute and tell us a little bit about that?
Hi there. So HIV treatment fatigue that I'm learning about through as an intern for my clinic is a multi-contextual issue where it could be internalized, internal, or like personal, a lifestyle choice, healthcare centered, social supports, or systemic. It is negative determinants that causes a person to not want to adhere to their treatment, and it could be both physical, but then also effort. That is psychological, emotional as well. So right now, trying to figure out what healthcare center determinants that clinics can have the ability to make an impact on to improving patients' adherence to treatment. Okay,
so your first problem was HIV treatment fatigue. And why is that an issue? Because people don't adhere to their treatment plan. And why is that a problem?
That is a problem because it causes persons to not be retained in care, or it causes persons to not have undetectable viral loads.
Okay, and why is that a problem?
That it's a problem for 2 reasons, because it can cause HIV transmission to persons not HIV positive, so persons that are negative. But then it also endangers persons that are positive from other persons because they aren't taking their meds and they're causing during unsafe sex to transfer the strains.
Okay, so increased transmission, right?
Correct.
Okay. And that's a problem because then
that's increasing negative health outcomes.
Okay.
So, or if we need to go back, increases transmission, which can increase diagnosis to HIV positive. Would that be the correct terminology?
Okay, so it increases HIV positive. And then we see Jen added a comment here on why people don't adhere to their treatment plan. She's right. So we could have another why and hear about why. Why don't people? So treatment fatigue, why is that a problem? Because people don't adhere to their treatment plan. Yeah, I guess that it can cause resistance, I see. So the fatigue is leading to, I think we can go in 2 places here. This is a great example, Sky First, because there's 2 different ways we can go here. We can go towards, is the issue really around the spread of HIV? So without undetectable viral loads, we are increasing the spread, or is it more patient-centered where, well, why aren't they adhering to their treatment plan? Do you have an idea around like why aren't they adhering to their treatment plan?
It's multi-contextual because it can be from the patient's perspective where it's self-efficacy, self-determination, motivation, because motivation is that huge determinant that causes a patient to have that buy-in and follow through to take their medication. But it's also healthcare centered in a macro way because there are certain processes and systems outside the patient's perspective that can cause them to not see why they're, like, for example, extra processes that are happening in the clinic that causes delays in medication or that causes delays in scheduling. Or like, for example, for me, because I'm a person that lives with HIV, having to take off time from work in order to go to get my medication or having to go to make that appointment. So it could be clinic processes as well.
Okay. So without, and I see substance use can also be an issue, trauma, diagnosis, fatigue on medications I saw is also an issue. So there's a lot of, and some of those, so we're getting at some causes. The effect is we have treatment fatigue. People don't adhere to their treatment plan. And would you say, if you had to, if we're thinking about treatment fatigue and you're thinking about the population you're working with, is the why this is a problem because of increased HIV transmission, or is it because of the multi-contextual issues that are yielding to patients not adhering to their plan and therefore just kind of not being as healthy as they could be, right? If I was to summarize that quite loosely, it is more about overall patient health outcomes, I think is what you're saying, and that the systems are failing them.
Yeah, I believe it's multi-contextual. It is a combination of patient, like internal patient processes that they have, they do have capacity and control over, but then there's also external processes that are outside of their control. It could be systemic. It could be like being like food insecurity or homelessness can cause a person to not really prioritize their HIV treatment and having to make that secondary. And then that compounds with intersectional like identities. Wow.
So I think if we were, maybe we didn't need 5 whys, maybe we started right on. So patients don't adhere. Sorry, you have to deal with my very horrible typing.
Totally fine.
Treatment plan. So we're starting to see where when we think about it from these categories, a lot of what you just said falls into these categories, right? So let's think about resources. You talked about food insecurity, right?
Correct.
Housing,
Transportation. Well, transportation could be also equipment.
yep.
And then resources.
Transportation could be equipment, yep. And then what else could be like adhering? Could it be actually equipment could be physically getting the medication, right? Availability of medication, or
it could for availability of medication, it could be pharmacy and hours or time scheduling. You could think of it as.
okay. And then let's think about some people issues. I think we talked about clinician issues, so case manager follow-up or clinical fatigue, right?
The atmosphere of the clinic, if the clinic staff represents the population, because I know if all the staff are white and the clinic sees persons of color, I know that there's going to be some adversities for persons of color wanting to go to a clinic that only has white staff.
Yep. Okay.
And then more so, in addition to that, for persons that are single tend to have higher degrees of treatment fatigue than persons in relationships and couples, because couples can motivate each other to take their medication. So does the person live by themselves or are they in a relationship with someone?
Okay.
Let me just jump in here for a second, just to let you know, we have about 5 or 6 minutes remaining.
Okay. Great. So Sky, as we look at all of these things, so people don't adhere to their treatment plan, and we are in no way done. So if this is something that is of
I'm doing this for sure later.
Yeah, if this is of interest to you, and I imagine it's of interest to many of you, we can absolutely make the slides available. Well, what I would say is continue to add to this and then begin to prioritize, because as we're seeing, you can't work on transportation and pharmacy hours. Pharmacy hours probably falls in that red category of things outside of your control. You can educate on pharmacy hours, like that might be something that you can do. Cost and insurance was something that came up in the chat, and that's again in the red category outside of your control. But maybe you can work on the atmosphere of the clinic and the relationship status, and understanding relationship status and the importance of that has, and maybe you can work on transportation and when you are offering appointments and how it fits into available transportation options. So I encourage you to continue this and continue to use this as a model. What can I tell you in the last couple of minutes? This is a great tool, and in no way can we do one in an hour and learn it and do it in an hour. It takes a long time to get familiar and comfortable with these, but as Wanda told us, she's the fish lady in Puerto Rico. And I love that because I love Puerto Rico first, but to be the fish lady in Puerto Rico says a lot. But it is an important tool for you to use. It begins to get the brainstorming. Sky was able to immediately rattle off some ideas. We got some great ideas in the chat. And so as you do this as a team, more and more things will bubble to the surface that you hadn't thought about as causes, or you hadn't kind of dove into the details around on causes. And so it gives you an opportunity to organize those ideas and then to prioritize. What is the biggest inhibitor to quality improvement? All of these ideas just rattle around in your head. You don't prioritize them and you get really overwhelmed and you don't do anything. So inaction is one of the number one inhibitors to quality improvement, because we just don't know where to start. Teams will say to me all the time, just tell me where to start. And I can't. You know your systems, you know your work, you know where to start, but I can help you organize all of that great information in your brain so that you start in the right places. So please think about using this tool as you're able to. Again, my email address was in the chat. Quality improvement is my first love. And so I'm happy to answer any questions as you get started on this and questions come up for you. Dennis, I'll turn it back over to you, but thank you so much for your time today. It's been a pleasure for me, and I hope it gave you something that's helpful moving forward.
Great. Thank you so much, Amanda. And thanks to everyone. Sky, thank you for that discussion, for stimulating that discussion. And to all those, I saw plenty of comments in the chat, but unfortunately, we ran out of time. So, but the presentation will be made available. And let me actually stop.